Good day and welcome to everyone joining us from wherever you are joining us. I want to welcome you to the 39th edition of Insight Webinar. Insight Webinar is a series hosted by eHealth Africa, and this series brings together public health professionals to discuss critical issues and explore ways to enhance healthcare delivery. My name is TJ Sojumu, and as usual, I'll be your moderator for today's conversation. Before I go into, the introduction proper, I'd like you to share the link of this call with friends, your colleague, people on your contact list, and everyone that you know should be a part of this conversation. Let them know that Insights webinar is now live. It's also live on LinkedIn too, for those who might not be able to join on Zoom. We're streaming live on LinkedIn. This is the 39th episode of Insights webinar by eHealth Africa. All right. Let me give a quick background for today's conversation. In January 2026, that's last month, the world marked World Cervical Cancer Month. And this was closely followed by the World Cancer Day, marked early in February. Now, this is not a coincidence. It shows how critical this public health issue is. The World Health Organization reports that in 2022, approximately 20 million new cancer cases and 9.7 million cancer-related deaths occurred worldwide, with nearly 70% of these deaths in low and middle income countries. For instance, in Nigeria, cervical cancer caused by human papillomavirus is the third most common cancer and the second most frequent cause of cancer death among women aged between 15 and 44 years. So addressing the burden of cancer requires a combination of public health initiatives and health system interventions. It is estimated that 30 to 50% of cancer-related deaths could be prevented through the modification of environmental and behavioral risk factors, as well as the control of infections. So this month's Insights webinar is titled Reducing Cancer Burden through Community Engagement and Behavioral Change. I'll read that again. Reducing Cancer Burden through Community Engagement and Behavioral Change. Now, this topic will discuss risk factors, the impact. It will highlight, evidence-based prevention and early detection. It would also emphasize the role of community engagement and behavioral change communication in promoting prevention, reducing stigma, and supporting sustained health-positive behaviors. Ladies and gentlemen, I welcome you again to the 39th edition of Insights webinar. Please share the link with people within your network and let them know that we're live. It's time to have this very important conversation. Now, today's panelists are leaders in public health and in the mental health space. And so I'm going to, in no particular order, introduce them, and then they will say hello to the audience. So let me read the first bio that I have. All right, so our first panelist is a registered public health nurse and a seasoned health promotion specialist with extensive experience in primary healthcare delivery in Bauchi State. He holds a Bachelor of Science in Health Education from the University of Maiduguri and a master's degree in health economics from Bayero University, Kano. He currently serves as the state health educator and health promotion officer at the Bauchi State Primary Healthcare Development Board, where he plays a key role in implementing primary healthcare programs and strengthening community-level health services across the state. His work focuses on health education, community engagement, and the promotion of immunization and nutrition initiatives. He has also actively participated in media and stakeholder engagement aimed at increasing public awareness of vaccination campaigns and other primary healthcare interventions. With his strong background in health education, economics, and community mobilization, he brings valuable insight into demand generation, preventive healthcare strategies, and efforts to reduce the burden of vaccine-preventable diseases and cancers. Ladies and gentlemen, welcome with me, Mr. Mohammed Ribado Jibrin. Good afternoon, Mr. Mohammed. Please unmute your mic and say hello to the audience.
Okay. Thank you very much. You're welcome. Welcome for this program. Thank you.
All right. Thank you so much, Mr. Mohammed. I'm looking forward to the conversation we will have in the next few minutes. All right. So the next panelist I'm privileged to introduce to you is a certified project manager. He's also a certified, business development professional with other certifications also covering monitoring and evaluation. He holds a master's degree in public health and brings over a decade of experience in the humanitarian and development sector. He currently serves as a project manager at eHealth Africa, where he has led strategic projects engaging traditional and community leaders to drive behavioral change across major public health interventions. His work has supported polio eradication efforts, measles, rubella vaccination campaigns, and increased HPV vaccine uptake through targeted community-centered approaches. Over the years, he has addressed critical needs across health, nutrition, education, WASH, gender-based violence, and child protection in Nigeria. He has strong experience leading sector coordination platforms at national, state, and local government area levels. He has worked with leading global donors and partners, including ECHO, the Foreign Commonwealth and Development Office, Bill and Melinda Gates Foundation, Gavi, the Vaccine Alliance, and UNICEF. And with his expertise in project management, stakeholder engagement, and large-scale immunization programming, he brings valuable insights into strengthening vaccine uptake and advancing efforts to reduce the burden of vaccine-preventable cancers. Ladies and gentlemen, let's welcome Mr. Salahuddin Sambo Ardo. Hello, Salahuddin.
All right. Hi, TJ. So thank you so much for this opportunity. Good morning, good afternoon, good evening. It depends on your locations. And nice to meet you online, everyone.
All right. Thank you so much, Salahuddin. We're excited to have you on this call. All right. So the final person I'll be introducing, not the least, is a licensed medical doctor at Chem Health and Diagnostic Center, where he is deeply committed to preventive care and public health education. He has a strong passion for improving health outcomes through communication and community engagement. He regularly hosts online health webinars and has led multiple medical outreach programs across urban and rural communities. And through these initiatives, he has educated diverse audiences on the prevention and management of chronic conditions such as hypertension, diabetes, stress management, and cancer prevention. His work centers on empowering individuals with practical health knowledge, promoting early detection, and strengthening preventive health behaviors. He brings valuable frontline clinical experience and a strong public health perspective to conversations focused on reducing the cancer burden and improving community health outcomes. So, ladies and gentlemen, welcome with me, Dr. Shalom Dam. Good afternoon, Dr. Shalom.
Good afternoon, Mr. Tjesu. Good afternoon, everyone. It's an honor and a pleasure to be here with you. Thank you.
Thank you so much, Dr. Shalom, and thank you to all our panelists. If you're just joining us, I want to welcome you again to the 39th episode of the Insight webinar series. And today we're discussing reducing cancer burden through community engagement and behavioral change. Kindly share this link with people who you know should be on this call, people in your contact. Please share on LinkedIn, on Facebook, and just to let you know, we're also streaming this conversation on LinkedIn. All right, so before we dive into our discussion, let's start by watching a short video, documentary, very short, and then we'll come back and begin to ask questions. All right, help desk.
We are here in Ungwagao settlement where the HPV vaccination is only targeting 9 years old.
Right now we are at Divine Care Academy where the vaccination is taking place.
There is ongoing vaccination of HPV here at Danja Settlement, Gezawa Ward.
I witnessed my neighbor. What happened to her is a really painful incident, and I don't want anybody to experience something like that.
Ni ma gaskiya da ban kai yarinyar nan ba. To na ga matsalar ta sosai. Dukkan su ne mutu na baya. Wannan yarinya ce da ta mutu Allah bai nufa in kai ta rigakafi ba. Kuma ga abin da ya same ta.
Fargaba mafi fargaba sosai. A ce yau yaronka ba shi da lafiya ko kai kanka baka da lafiya. A ce baka da ma inda zaka dosa asibiti da yake kusa da kai wanda zaka ga likita. Da kuma ya za a yi ma ka ga likitan ko kuma idan ka je a ce maka babu maganin da zaka samu. Kuma gashi akwai cututtuka da masu yaduwa.
A ce ciwo ya shigo babu wani rigakafi haka ko abin da za a tallafa haka. Ciwo mai yaduwa dole ne mutum ya yi fargaba.
So from the beginning, we had a co-creation with mothers, 9-year-old children, and gatekeepers.
Wannan shiri da zamu na yau haɗin gwiwa ne tsakanin hukumar lafiya matakin farko ta jihar Kano da haɗin gwiwar eHealth Africa da haɗin gwiwar UNICEF. Wannan ƙungiyoyi guda uku su haɗu suka shirya wannan taro mai albarka.
So da yawa mata suna foyewa bisa kunya da mata suke da fita su ƙi faɗa da kuma rashin sanin nuna su. Ciwon ya kawo kan lokaci ne tsawai wacce ba tare da ta ma san me yi a jikinta ba. Sai dai na gargajiya su baushe da makamantarsu kai kana ganin wannan ciwon wani abu da bai su. Wanda da na ji asibitin an gwada sai a gano cewa ashe ciwon sankarar bakin mahimmanci.
It gave the caregivers chances to go back to the community and discuss with their neighbors and other communities to know the importance of HPV vaccination.
Rigakafin sankarar bakin mahaifa mutane da yawa in an musu bayani suna ta cewa tsarin iyali ne ake yi don kar 'ya'yansu samu, to wannan abu ba haka yake ba. Shi rigakafin sankarar bakin mahaifa ciwo ne wacce ba ta da magani idan har ta kama mutum. Samu training sosai, mun gamsu da training don har mun zo mu ma mun je abinda aka koya mana mun zo kuma mun yada shi a cikin al'umma.
To da aka yi mana training an ƙara faɗakar da mu akan ma yanayin ya cutar take, ga kuma yanayin yadda za mu je mu ma faɗakar da mutane mu kuma nuna musu cewar muhimmancin yin rigakafin ma.
Wannan rigakafi an kira mu semina a kansa, an wayan mana da kai kuma alhamdulillah mun shigo cikin al'ummarmu mun nuna musu irin illar abin da yake haifarwa musamman 'ya'yanmu mata masu tasowa.
Duk wanda yake ci a rigakafi tana hana haihuwa ƙarya ne. Saboda na kai ‘ya'yana na sama daga baya na kai su rigakafi kuma duk na aurar da su dai haihuwar suke da su fasa ba.
HPV intensification vaccination that is ongoing in Kano State, especially the outreach session and then the school vaccination that has happened.
I am telling my students that they need to take it. Even that was what I told the female ones. They need to take it.
We have a very good supporting partners, the UNICEF and the eHealth, in collaboration with the state government. Are going to create much more demand and support.
I want to use this opportunity to thank all our development partners, right from the UNICEF, eHealth, that have been giving us support. So we thank you sincerely for this support. We are sure we'll continue to collaborate with other partners, and the state government is still ready at any given time to make sure that communities are fully mobilized to make sure that this cervical cancer does not feature in our children and the generation to come.
Forwarding our sincere approach to e-health Africa.
Okay. I think the video is completed. All right, thank you. Thank you very much, Help Desk, for that that interesting clip showing us, and the audience also too, the behind the scenes of, vaccination campaigns, especially for HPV. Thank you very much. All right, so if you're just joining us again, I'll welcome you to Insight Webinar. This is the 39th edition. I've introduced our three panelists, and we're discussing reducing cancer burden through community engagement and behavioral change. And just like the video we have just seen, there is a lot to do when it comes to behavioral change and community engagement, with respect to reducing cancer burdens. All right, so my first question is to Salahuddin. All right, so we just watched an interesting video, right, on eHealth Africa and UNICEF's intervention funded by the Canadian government on HPV, which is the #1 cause of cervical cancer. So can you tell us more about this HPV campaign? And also for those who probably, those who also watch this video are part of our audience who are just seeing this for the first time, they don't know so much about this campaign or even know so much about HPV. Can you tell us more about this HPV campaign? Salahuddin.
All right. Thank you so much, Tijesu. Can you confirm you can hear me?
Yes, I can hear you.
All right. Thank you so much once again for this opportunity. So basically, for the UNICEF project that was funded by the Canadian government, we get to implement it last year in collaboration with the UNICEF and the states, particularly in Kano and Bauchi states. So the project was actually community-based driven. We started from the bottom-top approach. So what we did in terms of HPV intensification, of how adolescent girls of age 9 should go and get vaccinated. So we started with a bottom-top approach of co-creation. So what co-creation means is that we worked with caregivers, parents, and then the state partners to co-create with adolescent girls in terms of understanding what is the information around the community and how do they get familiar with information around HPV. We reflected on some of the ideas around the information sharing, and then we pre-tested together with the adolescent girls, their parents, and then other partners. Then we actually used that information to do a school-based and community-based edutainment. Edutainment means a mixture of education and entertainment activities around recreational, which drives the adolescent girls to participate in schools in collaborations with the teachers, with the school board management committees, with the head teachers, and so on. So this created an avenue for HPV intensification, whereby these adolescent girls get to be vaccinated. Another aspect that we utilized was the essence and the importance of training teachers to understand the HPV, because we understand the myths around information, and then from our assessment and understanding that knowledge is power, so it is important we pass the accurate informations around HPV. So the teachers are the first line of actions in terms of school engagement. So we try to mobilize teachers and train them on HPV, more especially around what is the HPV, the risks around it, and the prevention mechanism. So another thing that we did is that we know it's an integrated response. So we tried to bring the health workers in. Then we worked with the state team to identify health workers around the Apex facilities in the local governments, and then we're able to train these healthcare workers because they are the frontline personnel, and they are the ones that administer these vaccines. So in terms of engagement with adolescent girls, it's virtually different with an adult. So in terms of engagement perceptions of healthcare workers' attitude and knowledge, were also reiterated in terms of working with these adolescent girls. So another thing we find that is very important in collaboration with the UNICEF, we realize that logistics in terms of going to outreaches in communities is very essential. So the HPV project supported the healthcare workers, more especially those ones at the front line, to be able to support with the movement and then the outreaches across all the settlements that were mapped out for the interventions. So I think these are some of the informations that we had during the implementation in collaboration with UNICEF and the Canadian government. Thank you.
All right, thank you so much, Salahuddin. I mean, it's listening to you speak about this in detail. It's impossible to argue that you were not there, in the middle of all of the action. So thank you for giving us this detailed explanation about what the HPV campaign was about. All right, so my next question goes to Dr. Shalom. Vaccination, as mentioned by Salahuddin, means early detection significantly improves cancer survival rates. How can health systems in Nigeria enhance accessibility and uptake of cancer screening?
All right. Thank you so much, Mr. TJ. So please, can you confirm you can hear me?
Yes, I can hear you.
All right, great. So, when it comes to our healthcare system, in Nigeria, we have the three tiers. We have our tertiary, we have the state, and then that's federal, state, and the local, which is like tertiary, secondary, and primary. Basically, primary level includes every primary healthcare center. It improves community outposts where the local government is in charge of that system and how it runs. The secondary is actually controlled by the state. And so everything regarding general hospitals and private clinics and hospitals is controlled by the state government. And then the tertiary is controlled by the federal government. This includes federal medical centers and teaching hospitals. Now, it is important to understand the structure of what our healthcare system should be like. Unfortunately, what we see is it's an inverted pyramid where the least amount of patients are seen in primary healthcare centers and the most amount of patients are seen in tertiary institutions. This puts a strain on how much work can be done in tertiary institutions, because imagine a patient who is having just a headache and a stomach ache from something that could just be a flu, but the person is at Federal Medical Center. Now, they would not be able to spend as much time to deal with the more profound or deeper cases that a tertiary institution is designed for. This puts a strain on how much work can be done. So, in order for us to enhance our health system, we need to look back into the structure and the tiers of our health system. Let's go back to bringing what should be in our primary, in our secondary, in our tertiary. Now, this, I believe, it involves not just the federal government, because in one of the research papers I saw, and this is also reported by the Nigerian Institute and the government, it says that 60% of healthcare systems are actually private, and only 40% of healthcare systems are public and are federally owned. So even if we keep pushing at the government and, putting as much fire at the government and telling them, we need this, we need that, they can only do 40% of the workload that is required. This brings us to the importance of specific strategic systems I want to share. Number one is for us to see the importance of leveraging on the primary healthcare force. We have people called community health extension workers. And just like Mr. Saluddin mentioned, they went to communities in Kano and Bauchi. And this information, if not for this video, I don't know how many people would have known that Canada was able to sponsor and work with people like this to be able to reach to these women who may not even be shown on the map. But this was very possible because when they went to the community, they reached out to the people who actually are giving care in those societies. So our community health extension workers, a lot of them, after being trained, they're lost. No one knows what happens to them. A lot of primary healthcare centers are ignored. And we won't blame them because over time there has been neglect in that area. There's not been follow-up training. There's not been enough kind of information that strengthens and equips them with the kind of care that should be standard for every citizen to be comfortable to go to those primary healthcare centers. So that's one thing we can do. We leverage on the workforce. We call them the foot soldiers in every community. Another way is adopting point of care technology. So we can enhance in every center where people have the vast majority of patients, especially when we look at the roles. We have people with different genders. Generally speaking, women have a higher health-seeking attitude and behavior as compared to men. So you find that we have more ONG centers. Now, these are antenatal clinics. We even places where we call them midwife clinics where people go to have gynecological care. So if these centers can also be enhanced and equipped with basic care to do proper early screening, that also strengthens it. And then finally, I'll say in this point, which is information, a major hindrance to the adoption of both the screening and early detection strategies that has been shared by the Nigerian Institute for Cancer Research and Treatment is misinformation, it's stigma, it's just that whole gap that is left as because of the interaction between people, the healthcare givers, and the patients, the public people. So if we are able to bring in, and this is one thing that I really appreciate eHealth Africa, these videos are not just negative information of what people are going through, but these are women who have they have received care, they have received information, and now they're the ones telling their story. We live in a system where the news that travels the fastest is negative news. How about we sponsor more positive testimonials from people who have become beneficiaries of early screening? These screening techniques are very simple. They are short and straight to the point. But a lot of times, because of the information, the misinformation of very few people who have had so-called bad experiences, it has made a general outlook that early detection and screening, it's aimed towards something that is negative. But we know and we have seen through countless information and research. I'll just wrap up with this.
Okay.
Okay,
Yes.
sorry about that. Okay.
Yes. So let's go to Mr. Mohammed, and I'll come back to you, Dr. Shalom. Mr. Mohammed, could you tilt your screen a little bit downward so that we can see your face clearly?
Okay.
Just move your screen downward. Yes, great. That's perfect. That's perfect. Thank you. All right. So, Mr. Mohammed, community-driven initiatives often determine the success of prevention programs. So, from your experience, how can communities be mobilized effectively to promote cancer awareness, screening, and vaccination? How can communities be mobilized effectively to promote cancer screening and vaccination?
Okay, thank you very much. Thank you for giving me this opportunity. And in the issue, when we talk about community mobilization, in the aspect of the public health, community mobilization goes beyond giving the information. It also involving the community leaders in planning aspect. So here, what we are trying to talk, how community can be mobilized in order to effectively promote cancer awareness, screening, and vaccination in a particular aspect. We cannot have that one without effective community mobilization for cancer awareness and also screening. In this aspect, we are trying to we cannot achieve all this, what the first speaker has mentioned, the second speaker has mentioned, without having a community mobilization content in our communities, so that by creating them, sensitizing them, organizing them, in order to have the community members' collective effort to address and share a health issue and develop challenges. All this content under the mobilization, we can achieve this one with the multi-sectoral approach. What we mean by this, there are some, especially in the context of this, our country, like what I can say in Bauchi here in the north, we have community structures that are very strongly influential in health behavior, seeking activity, behavior changes. Like by this, we can achieve this, creating awareness on this, how we can create awareness on this cancer awareness and screening and vaccination by focusing and engage in our prominent key stakeholders at the state, at the community level, which one, we focus on engagement, trusted community gatekeepers. That is our traditional leaders, religious leaders, the world development committees, women and youth association, community volunteers. These are all our trusted community gatekeepers that we can engage in order to see how we can create awareness related to this cancer issue at the state level. And also, as part of the activity, all these actors or the gatekeepers, by conducting advocacy, orientation, sensitization, and also developing the appropriate key messages that we can deliver to the community. And also, we can able to encourage our leaders to public endorsement and screening of the vaccination, and screening and vaccination in general. And also, we can use our religious leaders, which is imam and pastors, in order to have during the Friday prayer, Sunday sermon, all this, to talk about the health issue messages regarding to awareness creation in a particular aspect of the community, how we can able to create awareness. And also in that aspect, we can able to use our community strategies, that is by mobilizing, engaging the use of community dialogue, social mobilization platforms, in order to have this success of what we are trying to mobilize the community, by organizing the town halls meeting, conducting the compound meeting, and the sensitization, use of market outreach services, and other engagement like community dramas, and for group edutainments, like what we are doing here in Bauchi. A lot of this activity has been achieved in order to see how we can create, with the support of e-health and UNICEF, we have achieved a lot regarding how we can able to create awareness in the issue of cancer awareness at the state level, whereby so many activity has been conducted by conducting these compound meetings, sensitization, marketing outreach services, engaging drama by entertainment people, using of radio programs in local languages, that is in Hausa and other this. And also, when we are conducting all this activity, there should be a considering of what we are talking about. Like when we are delivering the message, actually we try to see how these messages can be useful to our community members by making some message to cover all this early sign of the cancer. When we are talking about the HPV, we talk on the cancer. Important on early detection of this cancer, and also availability of the screening services. We all talk safety and benefit of the vaccine, that is the HPV, and also keep the message very simple to the community so that they can be able to understand, because early detection saves life. Vaccine is preventable. The cancer.
All right, thank you. Thank you so much. Thank you so much, Mr. Mohammed. Please, if you're following us, if you have questions for any of the panelists, put it in the Q&A box. We'll take your questions before we end this webinar. And if you're just joining us, I want to welcome you again. This is the 39th edition of Insights webinar. We're discussing reducing cancer burden through community engagement and behavioral change. All right. My next question is for you, Salahuddin. You've rightly said you led HPV campaigns in Kano and Bauchi. What successes and challenges have been observed in reaching adolescent girls, especially in underserved areas? So, could you share with us what data you have? What successes and challenges have been observed in reaching adolescent girls, especially in underserved areas?
All right. Thank you so much, Tijesu, for this question. And I think one of the most interesting things that we recorded during our implementation in 2025 was for us to, as a team, to look at the baseline data using the DHIS2. So the baseline data for HPV uptake by adolescent girls of 9 years old was around, for Bauchi, it was around 50,000, if you look at the DHIS2 data. And then when we did the implementation in 2025, we were able to achieve over 321,000 adolescent girls were vaccinated, right? So this means that it's a very, very important data. The baseline for 2024 was around 50,000 people for the whole year that were vaccinated. But because of our interventions and the funding from the Canadian government and partnership with the states and also UNICEF, we're able to reach to 321,000 people. So that is massive for Bauchi. And for Kano State, their baseline data was around 23,000 vaccinations in 2024. But because of the intervention we had in Kano, we were able to reach over 233,000 adolescent girls within the age of 9 that were vaccinated. And this vaccination happens as a result of either outreach or school-based vaccinations. So what does that mean? It means that one of the success that we actually recorded apart from the data I presented was the integration. We realized that you cannot work alone. Health is everybody's business. So that means the health sector partnering with the education sector to drive demand gave this success. You can hear the second speaker talking about multi-sectoral approaches. You can hear the first speaker talking about the cadre of the layer of the implementation. So we didn't work alone. We realized that the health sector, the health space, can give an arm's length to other agencies like Ministry of Education, and we partnered, and this gives us this number. And another thing that was a huge success for us is around the stakeholder engagement. We realized that because of the certainty around that health is everyone's business, that means everybody needs to be involved and at the same level of information. So the turnaround time of the stakeholders in the states across all were at the front line. The commissioner was receptive, the health educators were the SIOs, the local government stakeholders, everybody was participatory because there was a high level engagement that was done by UNICEF, and then at the state level, eHealth supported with that engagement. So we didn't go in to say we want to vaccinate. No, we started with the engagement to create the awareness of what we want to do. And then UNICEF were very strong in the high level engagement. So that's three areas, that three components gave us that massive success in terms of having the DHIS2 data. So our challenges that we faced during the implementation, the first challenges was we went shortage of vaccines. I can tell you after all those engagement, all the vaccines for HPV, we had a shortage. You can see the state health educator mobilizing, working with the logistics team. How can we get vaccine? How do we mobilize vaccines from other states to utilize it? Because we created a huge demand and people came out, but along the line, there were a shortage of those vaccines at the healthcare facility. So that means our stock out was one of our challenge, and a lot of people had expectations. A lot of peer adolescent girls were wanting to be vaccinated, but unfortunately they couldn't because of the shortage. Another thing is security challenges were also part of it. If last year around November, December, there was a high level of security challenges. which led to closure of schools, within the northern states. You can see governments and governors giving directives in terms of close downs in schools. We experienced that in Bauchi, and then we also that led to some of the scale down of the implementations. Another thing that we experience, and is largely attributed to the resources. The high number of adolescent girls that we have in Nigeria, and then the rate of resources that is allocated to vaccine uptake is quite minimal. So funding constraint was one of the challenge in terms of HPV intensification, because now people are aware, so more resources needs to be plugged in to close the gap around cancer. So thank you so much to just.
All right. Okay, great. I was just going to stop you there so that we can go to another question again, because we looks like we have quite a number of questions also from the audience, and I'd like us to be able to take it. All right. So the next question is for Dr. Shalom, and I'm hoping that we can also deal this briefly so that we can move to the next question. So Dr. Shalom, cancer places emotional and financial burdens in patients and families. How can psychosocial support be scaled within resource-limited settings to improve quality of life?
Thank you very much, sir. Yes, psychosocial support and palliative care has proven to be very, very effective in helping patients at different levels, though especially those who have been affected, and those who have been screened, who have shown positive, and their entire cancer journey. A lot of times, the stigma that once a person has a positive result means end of life, that psychosocial support actually brings that down by a significant number. Now, there was a report that was made. A group of people did a research in a community in Osun State. They had interviewed 72 parents and 9 caregivers, just asking them what their experience is having lost someone due to cancer, or having someone who is dealing with cancer, or someone who was just previously screened. And out of 72 parents, 71 parents, 71 actually did not believe that cancer was curable or preventable. They believed that it was as a result of some form of, spiritual attack, or it was as a result of some kind of misbehavior. In fact, one of them was saying if her daughter was not promiscuous, this would have not happened to her. Now, these are expressions of emotions, but one very, very effective tool that this team used, because they went with 9 psychologists, and 2 of them were trained in child psychology. And they spoke with all 71 parents. They had time to speak with them extensively. And they found that at the end, those people who just were screened and actually started with the early treatment, they came back for follow-ups, and they were able to get to the point of remission for those who even had, a certain stage of the cancer and received treatment. So this helps us see that man on his own is a communal human being. And when there is that support that they can receive, not just by the outsiders, people who are the ones giving care, but also people who are in their home, their community. This helps support and helps to increase the chances of people getting into remission and even recovering. Another way that this can help us is through community-based approaches. There is a system that Botswana used where they created something called a teen help teen approach. Now, what this helped them do is people who had gone through screening and had come out, especially most of them with negative results, they created a group with them where they get to share their testimony of what happened. And those who were even positive were added to that group where they get to support them and tell them, see, the symptoms you're experiencing, I went through the same thing, but I feel better. And those people, in fact, they had better emotional support with that kind of concept. Palliative care has also been one that has been a struggle because most of that received in tertiary institutions. But one thing that has helped is the integration of non-governmental organizations and also specific state organizations and people who rally together, and they're able to help make that these treatments, especially pain management, is brought to a state and a cost that is easy for people to be able to acquire. And this has also helped people who are, of course, in their third stage or even fourth stage of cancer, and a lot of them come out with better outcomes because of that. They are getting the medications they require at the time that they need it, and they're receiving psychological support. And finally, is culturally tailored interventions, especially when we talk about people in the southern part and people in the northern part of Nigeria, for example. The way of approach for these two people is not the same. So one thing that can help us is understanding, just like every person comes from a particular state, encouraging people to look back to the state of origin. Where do I come from? What can I do? What training can I receive? That helps us to create support groups, even in communities. And like Mr. Sowidin said, that you can even talk to churches, leaders in churches, leaders in the mosque, leaders in different ethnic groups, and even the traditional rulers. This creates communities where people who are going through this, it's not it will not be limited to only those who have been screened or actually going through a disease condition, because that can also create stigma. But when you make it open and you make it that this is a safe space where everybody gets to receive support, we are living as a community, because that is what Africa and Nigeria is known for. We are a community-based people. So this would help strengthen the support that people can receive. Thank you.
Yes, thank you so much, Dr. Shalom. Thank you so much. All right, so I have one question. I'm going to throw it out for Salahuddin to respond to, and Mr. Mohammed Jibrin to respond to. And I'd like you to respond as briefly as possible so that we can I'd like us to take, as much questions as we can, given the limited time. All right, so first for Salahuddin. So partnerships with, organizations like eHealth Africa and UNICEF has been critical in cervical cancer prevention. So for you as a project manager within eHealth Africa, what lessons can be drawn from these types of collaboration for other public health interventions?
Yes, so I think based on the implementation we did, and the major lessons that we learned is from one activity that we have done, the co-creation. Because you want to address people's problem, you want to address community problem. So when we co-created with a certain number of participants, which is around the teachers, the adolescent girls, the parents, the caregivers, and the gatekeepers, we were able to extract information and we used that. But one thing we learned is that it actually happened at the state level. We need to go down to the local government and contextualize it based on local government peculiarities, because it will shock you to see that you are in a state and then the peculiarity of each local government differs, more especially in the states that we implemented. So when you co-created at the state level, but the peculiarity in Tafa Balewa is different from the one in Bauchi. For example, in Bauchi Metropolis, where you co-created, you can see that there are issues around elite non-compliance, meaning people have access to social medias and information, so they tend to digest that. But at the local government level, their own non-compliance is basically lack of information and knowledge. They are not exposed to those kind of facilities. So when you are co-creating, you need to co-create at the local government level, whereby you have decentralized the informations and then the ideations that you want to have in terms of engaging with all the participants. So that is one aspect that we have learned. Next time, if you're going to implement this type of project, we would like to co-create at the local government level with the stakeholders instead of having a representative across board. So another thing that we also learned was that the school clubs, the schools that we supported, initially they were health clubs in schools, and these health clubs are avenues where you start to reach out to students. So those clubs are actually on a scale down. Some schools, some government schools, I can't even be sure that they existed or those activities of the clubs are ongoing. But there is need to strengthen that health clubs in schools, and then this will encourage peer influence. This will strengthen the participation, the champions. The clubs can be now the champions or advocates of any type of diseases apart from cancer. So that's also one lessons we learn. Those clubs in schools needs to be reactivated, needs to be strengthened. And then
okay, Salahuddin, so I'm going to cut you there now. I need Mr. Mohammed to quickly also answer so that we can take questions. We have lots of questions, so I want you to be able to respond to those also too. All right, Mr. Mohammed. So quickly, in 1 or 2 minutes, what lessons can we draw from collaborations, for public health interventions like this?
Okay. So in terms of when we talk about the collaboration, based with I can say partnership with the e-health here in Bauchi and UNICEF, which have a significant strengthening in the cancer cervical prevention, and also has a contribution across the system, whereby the cold chain system, across the digital system, and also the community mobilization aspect, whereby they have already an issue of financing and also an issue of technical guides, which are some key lessons were learned throughout by the collaboration with these partners in terms of responding to our issue, more especially in terms of in the issue of HPV vaccine. They have contributed a lot. And also in the intervention on the public health intervention, like in the other aspects, we can able to have this issue of the outbreak response, issue of the nutrition, issue of the routine immunization, and even on the non-communicable disease control, whereby all these partners contribute a lot to make sure that they have put the state by contributing a lot to the government. And also this issue of the contribution has a significance in the aspect of when the government take ownership on the issue of this activity, whereby the government can clearly state the leadership, that is from the Ministry of Health, State Primary Health Care, which define the priorities of the partners, and also partners alignment to the state operational plan based on this operation. Not parallel system is conducted. All this one is part of the stakeholders that learn issues of the achievement. And also in the budget line must exist for the co-financing and sustainability plan, also this one. And also in that aspect of the collaboration, there's this community engagement must be structures and not what I say, not an ad hoc, so that the social mobilization determine the coverage, what the early engagement of the traditional and religious leaders, reducing the resistance, and also what development committees which improve the mile tracking of our at the community level. And also we have the issue of school-based and community-based strategy must complement each others at this sector. So they can able with this collaboration, a lot can be achieved in the issue of data, whereby the e-health, I can cite example with the e-health common data system driving accountability, which is as part of the role of the e-health, putting the state in digital micro-planning and also real-time vaccination tracking, all other this one, and GPS mapping of understanding the area. And also there are some of the understanding the dashboard on the daily.
30 seconds more, Dr. Ahmed. 30 seconds more.
All these were achieved with the collaboration of the partners, more especially in the aspect of the e-health, identifying the missettlement quickly with this issue of digital, and also supporting evidence-based decision-making with all this. And also, we cannot talk about the issue of collaboration without mentioning something related to the cold chain system of the state. This whereby all this collaboration can able to be and strengthening the immunization and the PAC system in general at the state level.
Thank you. Thank you so much, Mr. Mohammed. And I'm sorry for putting you on that marathon. I could see you moving very, very fast to share all your thoughts. But thank you very much. All right. So I have about 3 questions that I'm going to just combine into one because they are around the same thing from Deborah, Ayeni, Celestina, Vincent. And I'm going to shoot this to Dr. Shalom And please, as I shoot these questions to you, I'd like you to, answer them as briefly as possible, 1 minute, 2 minute top. So, so a lot of people want to know the HPV vaccine, is it only effective for a certain age group? What is the age range, if that's the case? And then someone is also asking, does it mean that if a woman does not get vaccinated in the particular age range, she has lost the opportunity to be vaccinated against HPV for life? So that's to you, Dr. Shalom, quickly.
All right, thank you very much, sir. So the first question, or let me just put it all together. So the age range for vaccinations, first is 9 to 14. The idea is to be able to vaccinate, prevent before the person gets engaged in sexual activity and then hence increasing the risk. So that is the first phase or the first time for scheduling for vaccination between age 9 to 14. Now, between 15 and 26, that is the age range for what we call a catch-up vaccination. So for people who may have missed the first 9 to 14, they can still get the vaccination between 15 and 26. Now, for the report we are receiving from the research and the World Health Organization and the CDC, there's not been significant difference or improvement or benefit for people who are above 27 to, although 27 to 45, they can still receive it, but the benefits has not been that significant within that age range or even after 45. So the best time is to catch it as early as possible because that's when it proves the higher chance of benefit for everyone.
Okay, thank you very much, Dr. Shalom. Let me quickly give you this one so that you could just also add it. So this person wants to know if the vaccine, okay, I think this question will be for Salahuddin. All right, so someone wants to quickly know if we have any of these campaigns around HPV in Sokoto. That's the first question. So quickly, if it's in Sokoto. Also, you had mentioned statistics of adolescent girls that were reached. Someone is also asking, based on the statistics you provided, what do you think will be the total estimated girls that you think we still need to reach in terms of percentage, right? That's the second question. Then the person also wants to know if this collaboration and partnership is only around HPV. But what about breast cancer? Is there any intervention given to people who are already infected? So could you just slam that together and give us?
All right, thank you so much, Tijesu. So with the intervention we did last year, Sokoto were just opportune to be part of the MR campaign, which is the measles rubella campaign. Unfortunately, Sokoto is not part of it. We're able to do it only for HPV. We did it in only Kano and Bauchi State. So I think that's for that. So can you confirm the other two questions so that I can wrap it up?
Okay, so the other question is about, do you have an idea of the percentage of adolescent girls that are yet to get to the vaccine?
Yes, so predominantly in terms of populations for the global age range, in terms of Nigerian context, we have the youths are between the age of 18 to 24. They have the highest population. So the largest population pyramid is between 18 to 45 or 35 based on the context. So in terms of the specific implementations of this HPV for adolescent girls, so what we can just say is that the target for 9 to 14, there is a huge number of gaps despite the coverage. And then that can be linked to the DHIS2 data you can see for immunization. So imagine people collecting vaccinations and the age of the people, and you can also link it to the numbers and the population of people that are engaged in the schools. So if you look at the education data, you get to see that the numbers of school children that are enrolled in school, you can have a sample. So significantly, I can tell you there is a lot of gap in HPV in HPV intensification, and that is why the uptake is very low. And I'm glad to also let you know that it has been returnized in 2023 and 2024. So what that means is now HPV is now a routine immunization activity. Is no more a one-off. You can go to the primary healthcare facilities and collect it with the normal doses. Thanks to Jesus.
All right, thank you. Look, a quick one for Dr. Shalom. Someone is asking if any intervention for a person who is already infected. Dr. Shalom.
Sorry, I didn't quite get the question, sir.
Right, so this person is asking, is there any intervention given to people who are already infected? Talking about care.
Oh, yes, absolutely. And that's where the importance of the stratification of help that can be received. Once someone is seen as infected, there are two other stages that follow, even after the point of care testing that showed positive. So the HPV testing shows that this person has the virus, but then there would be a second test, which helps us to see the lining of the womb, which is the cervix, also looking at the cell. So if there are transformation zones, there is a point of care treatment that can be received at that point. So the first thing is, if someone has tested positive, the person needs to go to where they can receive the first care of primary intervention. Now, depending on what comes out, the outcome of that. In fact, that's why early detection is the best, because at that point, a lot of people can get free. And of course, they have follow-ups and they are monitored psychologically and also in other ways, of course, for their health. One thing that also helps is after the second stage, the third stage. Well, let me just say, this is where there's a little disparity in information we're getting, where some people get lost after that first time. So they find they're positive, they run away, they go to so many places and get, situations that are worse and come back in third and fourth stage, which is where a challenge comes. But if a person who is positive, they go straight and receive the first care where a primary intervention can be applied to them, this also helps to limit progression into more severe complicated stages. So there is.
Thank you, Dr. Shalom. So I think I have two more questions that I'd like to take briefly. One for Mr. Mohammed, and again, still one for you, Dr. Shalom. I think it's important. So someone is asking, how can you convince girls with cancer that cannot express it to others just because they are ashamed to talk about it? So, this is a behavioral related question. So how do you convince them to open up and talk about it and, seek counsel and things like that? Briefly, have you had to deal with such a situation, and what can you advise?
Okay. So
yeah, go ahead.
No, sir, please go ahead, sir.
No, go ahead, sir. Yeah, the question is for you.
Okay, sir. Thank you very much, sir. All right. So, one experience we had was with a lady who was 18 years old, and she actually had the HPV screening done and it came out positive for her. So the first thing we did was to call her and have a separate discussion with her where we counseled her first. We had to help her see what HPV really is and to let her know that for the fact that you had it for the first time does not mean you immediately have cancer. And that was something that actually helped calm her down and decrease the anxiety. We also went forward to connect her with one of our nurses within the team who continued to follow up with her. So when she got that confidence that this is not the end of the road, this is, in fact, I can use my story to help other people. There was a community of young ladies who were in a school and we went for an outreach. We went with her. And she was able to share her testimony because everyone would see her and see that she's healthy, she's happy, she looks very good. And so telling people, yes, I tested positive, it reduced the stigma. And for her, she felt proud. Everyone wants to feel heard. Everyone wants to feel like a hero. And so you being someone else's hero encourages them to actually speak up about it. But it first starts with having the right information and the right kind of support for them. Thank you.
Yes. Thank you so much, Dr. Shalom. Thank you so much for that. All right. So the last question to Mr. Mohammed. So someone is asking this from Ibrahim. He says, community engagement is very important for success, especially in rural areas. So this is my question. What steps are being taken to address communities that distrust government programs due to traditional beliefs?
Okay. Thank you very much. When we talk about the issue of belief we talk directly on the traditional belief that people has. In the aspect of the SBCC, when we are talking about how we can able to change the behavior of our community regarding to this HPV or any related diseases. First of all, we consider the community by engaging their community-based participatory approach by developing a trust and the ownership so that we can able to engage our traditional and religious leaders, prominent people, in order to address this gap or this issue that people are having belief on this negative aspect of the diseases. And also, when we are trying to have this, a lot of structures, strategies, methods, we are engaging at the state level in order to see how we can able to address this issue at the community level. More especially that you talk about the rural areas, whereby they have so many misconception, belief, norms. All this one is attributed to the belief that they have on this issue of the why they are having this, so that we can able to engage a prominent stakeholders at that level by engaging the religious leaders, traditional leaders, our community resource group, that is the volunteers we have. They can able to at least address their concern so that they can able to believe on this issue, what we are saying. We can able to achieve this by engaging this our gatekeepers and other prominent people. And also the health workers play a vital role in order to sensitizing the community, either by gathering them in a one place or the issue that they have related to their community, whereby they can able to address all this issue. Yes, that's one of it.
All right, thank you, Mr. Mohammed. Thank you, Dr. Shalom. Thank you, Salahuddin. Thank you for everyone that joined us. And if you put up a question on LinkedIn and I didn't take your question, I apologize. By the next edition, I promise that I'll take the questions coming from LinkedIn. But thank you, everyone, for staying to the end of this call. Thank you for putting your questions. I would say, Dr. Shalom, you can type your LinkedIn, link, and put it in this box. Or you can go on our social media. I think we tagged you in a couple of our posts. You can also follow Salahuddin. If you have more questions about the work that he's leading in Bauchi, in Kano, you can follow up, with him, and also follow up with Mr. Mohammed to ask, more questions about this subject matter. We can definitely, and we should, take this conversation beyond, this webinar. But I want to say a big thank you to everyone. Thank you so much. I appreciate you. We're inviting you to follow us on our WhatsApp channel. The link is in the chat box. Follow us on our WhatsApp channel so you can get updates about the activities of eHealth Africa. Follow us on our social media handles. We're very active on LinkedIn, on Instagram, on Twitter. Please follow us and stay up to date with the work that we're doing in health systems strengthening. So thank you very much. This brings us to the end of this webinar. And until the next edition in the month of March, this is me signing out. Thank you.
Thank you very much. Thank you.
Thank you, everyone. Bye.
Thank you, everyone. Have a nice day.